Now, Professor Oswaldo Castañeda is an authority, not just in Peru, not just in Lima, where he has his practice, his Clínica Angloamericana, but also in the entire Latin American continent. And it is an honor to have him here to speak about the duality between osteoarthritis and arthritis, present and future. Dr. Castañeda, welcome. It's a pleasure to see you again after a few years. And you look as young as always. Well, thank you very much. Good afternoon to you all. I would like to express how happy I am for two reasons. First, because I was able to take part in 2017 in the first OAFI Congress and get to know all of the incredible task of Dr. Vergés and all others working along with him. So I feel very honored for being here once again with you and being able to contribute to the important work that you carry out. As I heard this morning, the Spanish Rheumatology Foundation and the experts have warned about the impact of osteoarthritis. 1/3 of those over the age of 50 suffer from osteoarthritis. What does this mean in Spain? Well, it means that there are more than 7 million people with OA. This is something Dr. Vergés already said. And OAFI, in information disseminated over the internet, said this: OA has increased more than 70% in 20 years, and it's still increasing. It's only logical, because people are getting older and older. The population is aging. And this shows how important it is to carry out this task, to carry out all the action that OAFI does. Now I would like to show you a few things so you can understand what I will be referring to. Itis is a suffix. That's the end of a word, which means inflammation. So when we say arthritis, it's arthros, which is joint, so it means inflamed joint. Monoarthritis or oligoarthritis is a few joints, and polyarthritis is many joints that are inflamed. Osis means wear or wear and tear. So when we say osteoarthritis is a worn joint in Spanish. These are two important concepts that we need to understand when we're referring to these things. What is arthritis? That's an inflamed joint. And this occurs in many diseases. There are many different diseases that swell or inflammate one or several joints. There's rheumatoid arthritis, the one known as the deforming arthritis, psoriatic arthritis, which occurs in part of the people suffering from psoriasis, goat's arthritis, uric acid, but also infection in joints. This is called infectious arthritis. Or it can be because of trauma, and it's called trauma arthritis. It could even accumulate blood. But there are other diseases, such as the so-called connective tissue diseases, systemic erythematous lupus, vasculitis. All of these things can inflame the joint and provide arthritis. We see arthritis in a vast amount of different conditions and for many different causes. Another thing important to keep in mind in medicine is that when we use the word degenerative, we, the doctors, are not referring to a pervert, we're referring to the aging process. Osteoarthritis is therefore a degenerative disease, often referred to it that way, and it's because of the wear and tear of the bones, cartilages, or others. But OA is a degenerative disease, but there are many other types of OA. Some not only have this wear, some present with inflammation, and others occur during menopause, affect youngsters or even children. And now I would like to reflect on something else. It's important to understand that osteoarthritis is not a disease. It's a set of diseases, of different ones. What must be understood to understand that in studies, you don't need to put everybody in the same sack. You need to differentiate, distinguish what kind of OA the patient has in order not to mix different types and provide just one treatment that will not resolve the issue in all, but only in those that have the type of OA that will respond to that treatment. This is the mistake of clinical trials since the very beginning to the present day. Up to now, there's lack of knowledge that when I want to test one drug in osteoarthritis, I cannot put everybody in. I need to distinguish whether the drug is for inflammation, for regeneration, for wear and tear. And we need to separate those patients who have one situation or another so that they can benefit from the treatment and so we can achieve more precise results. There is another way. And we need to understand that OA is not a disease. We rheumatologists call erosive osteoarthritis is a self-immune entity that yields OA alterations, which also destroys the joint and behaves like a rheumatoid osteoarthritis. So this disease is in the middle of a spectrum between osteoarthrosis on one end and rheumatoid arthritis on the other end. Even there are alterations of the wear and also with an inflammatory cytokine. All of these things are important because we need patients and doctors, especially specialists, to understand that we shouldn't just say osteoarthrosis. We should distinguish the type of osteoarthritis we're faced with. So we need to understand what I already said. Osteoarthrosis is not a disease, it's a group of different diseases. And this is very important for my concept. We need to understand that the doctor cannot just remain idle, being a mere spectator when faced with a disease, and the doctor should never be behind the disease. Sometimes the disease, when it comes, it's an aggression that will cause damage and will continue to damage more and more. So the doctor must be ahead of the disease, preventing it from progressing and damaging the patient. The doctor should always be ahead of the disease. So what about the future? The future is rheumatoid arthritis or osteoarthritis. We already achieved the total remission. But sometimes one is happy to see a remission in the conditions, but the full, real remission is when all symptoms disappear and the patient is fine. Also, when the lab markers also show normal results. The patient may be well, but if the lab markers show that there is inflammation, then we are putting out the fire, but not the sparks that may be left, not the embers. This is what happens with inflammation. Inflammation must be controlled in full, in the way the patient feels, and in the lab tests showing that everything is correct. So this is the true complete remission. But we are on our way to curing self-immune diseases. So we need to emphasize that there's something very interesting here that is related with the correction of the microbiota. The microbiota is the alteration that triggers the unsuitable reaction of the immune system. And why? Because we are born 100% human. But when we leave the womb, we get filled with microbia, not just in our skin, in our respiratory tract, digestive tract too. And we become people with 10 microbes for every cell in our body. So in actual fact, once we are born, we are 90% microbes and 10% humans, because there are 10 microbes for each cell in our body. But if we talk about genes, the situation is even worse, because we all have more than 100 groups of different microbia, and each of these groups have a genetic code. However, our cells have all the exact same genetic code. So in our body, there are more than 100 genetic codes, and then another one, which is ours. So that's why there is an unbalance in the microbiota, and we have dysbiosis. This genetically affects the influence on the immune system, and we see diseases emerge. That's why we hope that the entire research conducted since the year 2007 with microbiota will lead us to, in a few years, the cure to all of these diseases. And the other thing I wanted to say about the future is,
according to what I said, that the doctor has to be on top of the disorder, is that we have to disseminate and insist on the need that all the ailments of humans require regulations and actions focusing on prevention. Preventing is important. And in osteoarthritis, the same. The future of this is to achieve total remission, that the patient who starts with osteoarthritis could be completely cured. And for that, we obviously have to benefit from the actions and the products that help us regenerate, others that help us cure, and including microbiota in osteoarthritis. And let's not forget that the most important is that one day in the world we can ensure that all the healthcare actions are merely preventive so that patients don't develop so many ailments. So the fundamental actions focusing on osteoarthritis, prevention, educating, early treatment and regeneration. Prevention. To prevent, we have to understand that there are risk factors that predispose to one or other condition. In osteoarthritis, risk factors, we need to understand them, disseminate, educate the population so that we see less presence of these risk factors in people. Diet, another important thing that has to do with microbiota, physical activity, vitamins, antioxidants, and of course microbiota, as we mentioned. Now the risk factors in osteoarthritis, firstly genetics. And I understand that there's a lab test supported by OAFI that can study the genetics of people to see if they have a genetic predisposition to osteoarthritis. And then age and weight, as we heard, the defects in the alignment of the limbs. If I have a lower limb that is somewhat deviated, it will wear more. For example, the knee joint will wear out more, and it will lead to early osteoarthritis. Sports as well, because excessive exercise is also one way of damaging joints. And if we don't use things that help protect our joints, all the more so. And the other things would be lesions and disease. If I have a lesion in a part of my body, I will obviously have a greater chance of wearing out that limb. And then diseases, as we heard several times, comorbidities. This is the test considering the genetic condition promoted by OAFI, which is very important because it already helps from an early age. That helps us have an idea of what could happen because there's a genetic predisposition, and so we would find prevention actions and mechanisms. Another thing that's important is age. When we turn 60, we have age-related inflammation. In English, it's called inflammaging. And what happens? When we reach 60 years, as most of you will know, our functions slow down. And some things we produce are also slowed down. And so at 60, the immune system produces less white blood cells, the T cells. And the person realizes that the T cells are less, and what do? It sends the order to increase the inflammatory cytokine levels, which are inflammatory substances. So at 60 years of age, because we have less T cells, which are a kind of white blood cells in the immune system, we have these inflammatory substances, cytokines, and at 60, we undergo a state of permanent inflammation. And so this predisposes us to develop many problems. So we need to understand that from 60 onwards, we start with inflammaging. Another thing is overweight. Overweight, if it's at an older age, it's more important. It's a condition in which there is an increased release of pro-inflammatory adipokines, substances that are parallel to cytokines, and any person who is overweight is always under permanent inflammation. And this, which we have known for many years, This is a paper reviewing this in 2009. And the authors were surprised to see that in COVID, the most important risk factor was older than 60 and obesity. What's the surprise? If COVID is a virus that develops autoimmune inflammation, and it's just making things worse if I'm obese or more than 60, because I already have inflammation. So obviously this should be a risk factor. These are important things in risk factors. Another important thing related to help prevent osteoarthritis is diet. A healthy diet with substances that help improve the health status of the person. There are many. For example, olive oil, the delicious olive oil you have in Spain, which has anti-inflammatory actions. There are scientific studies indicating that olive oil has anti-inflammatory effects, just like ibuprofen. So these things are important, and other things like other products that help us improve the health status of the structures in the human body. Physical activity is another important thing. For example, one of the ingredients that would be very, very beneficial would be turmeric. Physical activity. Many people older than 30 already have knee osteoarthritis. I will turn 72, but when I was 40, I played football, volleyball, basketball at 40. I already had osteoarthritis in my knee. It's important to understand that sports also predisposes to these things. And the most recommended physical activity is one in which the joints do not have to bear any weight, which would be anything that we do in water, not just swimming, also walking and other exercises in the water, which is very important because in the water our joints do not have to bear any weight. So this removes something that wears the joints out and it keeps them healthy.
Y la otra cosa son las vitaminas y los antioxidantes.
Then we have vitamins and antioxidants. Vitamins are very important, especially vitamin D. And antioxidants, that's why it is so healthy to drink some wine every day. It is recommended to have 3 ounces a day. For all who have prepared baby bottles, you will know that every ounce is 30 centimeters. So the moderate intake of red wine is 3 ounces a day maximum. Because with that, a Friday or a Saturday evening, you can have 5 ounces or maybe 6 and enjoy good company a little more, so long as the other days you take 3 ounces, because the recommendation is to have red wine every day, but it's not universal. Some people have migraine and they cannot drink red wine, but other people, the little alcohol in wine produces arrhythmia in their hearts. So not everybody can benefit from this, but those who don't have these problems can definitely benefit. And red wine has over 600 substances in it. Those substances are beneficial for our health. So 15% alcohol proof in red wine. It's alcohol, and usually alcohol is counterindicated and is harmful for our health, but the many substances, beneficial substances for our health in red wine exceed by far the little alcohol in red wine. So red wine should not be considered an alcoholic drink. if taken with moderation. If I drink a bottle every day, it certainly is alcohol, and I will die of cirrhosis. But taken moderately, 3 ounces per day is beneficial, and the alcohol content does not harm us. The other thing is the gut microbiota. We heard about the importance of microbiota, which is so very necessary for the balance of our health in human beings. So what actions should we carry out? In patients with osteoarthritis, if you have inflammatory osteoarthritis, or if you have metabolic osteoarthritis, which is also inflammatory because of obesity, we have to use anti-inflammatories, but different in every circumstance. We must also use medication for microbiota. Currently, we have probiotics available, but they are unspecific. Research is trying to achieve microbiota products that are specific, so that when we study microbiota in people, which is done very nicely here and very detailed in Spain, we see what is further needed, and that's what we give, because when we just give them any probiotic, it is completely non-specific, and we will not we will not tackle the problem specifically. Another thing is regenerative medication. We have many things that we have to use, and anti-aging medication, which we have many things available now. Thank you.
Muchísimas gracias, doctor Castañeda.
Thank you so much, Dr. Castañeda. Instead of water tomorrow, why don't I get a glass of wine here? Any questions for Dr. Castañeda? Castañeda, sorry.
Bueno, ya viene Monse, nuestra deportista. Adelante, Carmen.
Bueno, muchas gracias por su explicación.
Thank you for your presentation. It's been very educational. At the beginning, I have osteoporosis, and we were told that we could not have osteoarthritis. Dr. Vergés has proven that besides osteoporosis, we can suffer from osteoarthritis. So my question is, how can I treat both things? If we have one medication, osteoporosis is degenerative, as you'll know, what can patients do if we have both conditions? A very important question, because as I said in the beginning, there are many kinds of osteoarthritis, and one of them is inflammatory, mechanical. Other kinds of osteoarthritis are osteoporotic osteoarthritis, because there is an important relationship with one another, as that is also very much related with muscles, and with age our muscles decrease in size, and that's called sarcopenia. When one has osteoarthritis, as in your case, it could be osteoporotic osteoarthritis. We have to treat osteoarthritis, we have to treat osteoporosis, and sarcopenia as well. Also, vitamin D is very important. Vitamin D has many functions. Vitamin D increases the number of muscle fibers and increases the thickness of the muscle fibers. Vitamin D produces anti-inflammatory substances, anti-inflammatory cytokines, and decreases the pro-inflammatory substances. So vitamin D plays a key role. Very important. It produces two antiviral substances, catalycidins and defensins, which block and destroy the virus and the envelope. And why is this important? Because about half of the population in most countries worldwide have a deficiency of vitamin D. You have to measure the blood levels, vitamin D blood levels, to see if you need supplementation. If it's at normal levels, you don't need it, but if you are vitamin D deficient or insufficient, you need supplementation. So, vitamin D for muscles, osteoporosis, osteoarthritis, and treatment for osteoarthritis and osteoporosis. We heard very much about microbiota. Some say it is the second brain, full of microbes and bacteria. We are water, bacteria, and collagen. Yes, my question has to do on microbiota. You spoke of the future of microbiota, and my question is, thank you for your presentation. My question is, are there any studies, finished studies on microbiota vis-a-vis inflammation, and what strains have you studied regulating this inflammatory state in the joints in osteoarthritis? There are many studies. There are studies in osteoarthritis, in rheumatoid arthritis, in spondyloarthritis, in psoriatic arthritis, and each one of them have a clear idea of the strains increased and decreased in that condition. Not necessarily is everything decreased or increased. In some cases, both things happen, but in others, there's an increase of something. In others, there's a decrease of something else. It's important, but it differs even amongst patients. So it's important to carry out the study on microbiota, even if there's a condition that is more or less standardized. But the study is important to see if you are missing this, you have to be given, or you have an excess of that, you have to receive another kind of microbiota to fight against the one that you have an abundance of. This is what is being worked on for the future, which I'm sure will solve many problems. So there won't be food supplements that would be standardized, because it will depend on the person. Yes, precisely, because always remember, as the doctor said, it's not just the condition, it's the person. Every individual has a disorder that not necessarily behaves like the same disorder in another person. In rheumatology, in general, in medicine in general, one must learn to manage the patient's problems, personalizing the treatment. Before Dr. Vergés wants to ask, I'm waiting for my colleagues to tell me if the next guest is prepared. We have an online speaker now. So, Dr. Vergés, a few things. I think diagnosis is very important. The diagnosis of the disease, as you've explained very well. We have to have the right diagnosis of the disease, because every patient is not the same. And this means that healthcare professionals must ask the patient, feel the patient. It's okay if you touch a knee. I don't think any knee has bitten a doctor's hand. So you must touch the knee, you must ask the patient, you must see the patient. And another thing, patients also have to ask, and patients have to speak, and you have to explain what happens, because doctors are not soothsayers, and depending on what you say, we will interpret one thing or another. Many times some patients are passive. And some doctors, some patients will say, will ask, they know very much, and they say, oh, I need a prosthesis, right? Would you get it? Would you give it to your mother? Do you think I will do okay with a prosthesis? And you'll see the doctor's face. Look, given your age, you're hypertensive, renal failure, let's just forget it. Let's treat or not, or let's go for it. So the diagnosis, as you said, is fundamental. Every person is different. Many times, doctors don't know at all. I've been a doctor for 38 years, and all I know is that every day I know less. So we have to be very humble, and we have to treat patients and wait for an answer. And maybe we have to change the treatment, because maybe the treatment we gave them, because every patient is different, we have to change. But we have to do this together with the patient. And to finish, I want to congratulate you for your talk. You can imagine, with Dr. Oswaldo Castañeda, we've known each other for many years, and he and I have seen each other in the best places in a congress, in the poster session. In the poster sessions, we only have nosy speakers like ourselves to see what is being said. We would meet there, not in bars, in the posters room. I have this patient here, I have that patient there. With Dr. Castañeda, we've been working for years. He's an excellent rheumatologist, presiding the Peruvian Rheumatology Society, an amazing CV, and someone who is a pleasure to have over here. And, oh, there's a question.
Sí, para terminar, es que...
Yes, to finish. Dr. Vergés likes to talk a lot, and we are not doing well time-wise. We should have rheumatologists like yourself here. Never retire, please. Before the next question, I've been asked many times, and I said, I will stop seeing patients when I die. I will never stop. Being a doctor is not a profession. It is a responsibility, and it is a profession as well. And the same, as I said before, teaching medicine is not a profession. It is a responsibility and a profession. And with Giuseppe, we've known each other for many years. I also like to talk a lot, and we enjoy our conversations together. If there's something important that I always said to my patients since I was young, was that forget that prehistorical attitude that the doctor is paternalistic and patronizing. The patient has to be clear that they have to know how to demand to the doctor, because one goes to be cured, not just to go and be given any other thing. So you always have to get used to the patient should demand to the doctor for a good explanation, for good alternatives, and to learn about the alternatives with all the information given by the doctor. I think it's important. I believe there was a question over here. Yes, I'd like to know, is it true that for vitamin D to be better taken by the body, does it have to go with vitamin K? And some say that there's a risk that calcium would be fixed in the soft and not the hard structures. How do we have to do it? Yes, that's important and related to osteoporosis, but vitamin D, like vitamin K, are liposoluble, contrary to vitamin C, which is water-soluble. What does this mean? Vitamin D, when we take it, it will impregnate in the fat tissue. and it doesn't need anything else there. It just stays there and is released as we need it. Perfect. Okay, so it's important. You don't need vitamin K. Vitamin D is enough. And the other question was? Calcium, right. Calcium. Calcium carbonate is not good. Calcium citrate is what's important. That has been studied in Bilbao. The difference between calcium citrate and carbonate, depending on the person, the calcium levels and the diet, it could be necessary that they take it every day, but most should take it 2 or 3 times per week. And calcium is a mineral, not a vitamin. Vitamins have to be taken in the morning because the circadian rhythm makes it so for vitamins to be absorbed in the morning, and minerals are absorbed afternoon. Calcium must always be taken after lunch, never in the morning, because it is not absorbed.
Gracias, doctor.